All right. Hello, everyone. Welcome to the Ohio Department of Mental Health and Addiction Services Crisis Academy on Ohio's crisis initiatives. I am behavioral health authorities. We're so glad you could join us this morning. I'm just going to run through a few housekeeping items as we begin. We will be using Zoom webinar today, so you would not be able to use your microphone or video, which means we cannot hear you or see you. The chat function is also disabled today. However, we will be able to send you information through the chat. If you have a question during the presentations, feel free to ask those questions to the Q&A box. We have reserved time for Q&A at the end of each panel presentation. Please keep your questions related to the content and topics we are learning about today. If you have any technical difficulties throughout this training, please contact me. I will be posting my email in the chat box for your convenience. In regards to continuing education credit, this training has been approved for 3 credit hours for the following disciplines: nurses, social workers, counselors, prevention, and chemical dependency professionals. By logging in today, your attendance is tracked. We will not be awarding partial credit. We encourage you to stay the entire time in order to receive full credit. Please note that we are also unable to verify attendance for those who joined the webinar by phone today. After the training, I will send an email that includes a link to the SurveyMonkey that will allow you to evaluate the training. Please complete this evaluation within 1 week in order to receive CE credit. Also, please ensure that you provide your license number in this evaluation. After completing your evaluation through SurveyMonkey, your CE certificate will be emailed to you within 2 weeks. This webinar is being recorded and will also be posted on the Ohio Department of Mental Health and Addiction Services website. This Crisis Academy will be facilitated by Fonda Freeman, Associate CEO of the Ohio Association of County Behavioral Health Authorities. I'm now going to hand it over to Lori Chris, who is the Director of the Ohio Direct Mental Health and Addiction Services.
Good morning, everyone. Thank you so much for the introduction. I just want to welcome you. I'll do this quickly because we have such an important agenda and great guest speakers today. But want to thank you all for joining the Crisis Academy today and for also being part of lifting up a full continuum of crisis services and supports across the state of Ohio. I can tell you that we are one of a handful of states that have dedicated ourselves at the state and local level in partnership, and both public and private partners coming to the table to focus on the full development of a crisis continuum to make help more visible, more accessible, and more robust in its outcomes for the youth, families, and men and women that are served through our system across the state. So that's a point of pride for all of us. This is a top priority for Governor DeWine. I know that making sure that people have access to care and that care is provided in a healthcare, behavioral health care setting, and that people aren't experiencing adverse outcomes from their mental health crises or addiction crises is something that he's spoken very passionately about and is top of his agenda. So grateful to be here today, welcoming all of you. I also want to acknowledge that these crisis academies are something that no other state is doing either. And I want to thank all of our partners in planning this, OACBA, the Board Association, for your work in lifting these up. We've been working with the PEGS Foundation, the Ohio Council for Providers, the families through NAMI, peer support providers, in lifting this up so that we can bring those best practices from across the country to Ohio so that we can collectively learn about what's working and what the outcomes are and for whom, and how to consider implementing these best practices in Ohio in ways that make sense at the local community level for the diverse populations that we serve in our state. So this, again, these crisis academies are a point of pride. Today, we've got a bit of a different focus. We've spent 10 crisis academies bringing in these national experts. This is our 11th crisis academy. And today we're going to hear from people who are implementing the work on the ground, what their experience has been, and the opportunities to look at the challenges and the successes and help continue to carve a successful path forward. So I'm really grateful for everyone who's here today. to share their experience in lifting this up. We're going to talk about 988 and the opportunity to have this call center stood up and the outcomes that we're seeing. You'll hear from Doug Jackson, who is our new 988 administrator for the state of Ohio, and learn some more information around what's happening there in the implementation. And we'll also be talking about OhioRISE and the opportunity to better serve youth and families in Ohio who are in crisis, and then help them succeed in their recovery long term. So looking forward to that. We'll also be talking about the Crisis Task Force, and I want to thank Captain Parrish for his time here with us today to talk about his experience on the Crisis Task Force and what that's meant to contribute to this larger statewide vision, and also his personal experience in implementing the work at the local level too. I know that all of you are anxiously waiting for the report from the crisis landscape that was done in tandem with the Crisis Task Force. We are working through the final drafting of that so that it can be easily digestible and usable by policymakers and constituents across the state. So we will provide some overview and update on that today. And we still are aiming to have that report introduced or released yet this fall. So we'll be giving you some glimpses today, and that report will be released soon. And I think with that, I will give it back to Fonda, who's going to be our MC for the day, right? Your host. And thank you again, Fonda, for you and your leadership and OACBA's partnership in lifting these crisis academies up.
Thank you, Director Chris. And once again, thank you for the Department of Mental Health and Addiction Services for their efforts in helping us spearhead these crisis academies over the years. And with that, as Director Chris, as well as Molly mentioned, my name is Fonda Freeman, and I'm with the Ohio Association of County Behavioral Health Authorities. And I'm going to be one of the ones assisting today in facilitating our session. We would like to set the foundation of today's Crisis Academy with hearing from an individual who has worked with her son navigating Ohio's crisis system. I'd like to introduce to you guys Nancy Lyons.
Hi, everyone. Thank you for having me today. I really appreciate it. So I was asked to talk about some times that I would classify as a crisis for my family or for my son. And I'm going to be honest with you, it wasn't easy because we've gone through quite a few, I would say, crisis situations over the last 8-9 years. But two came to my mind very quickly. So those are the ones that I'm going to share with you today. In October 2016, my son had been in and out of the mental health this world for a while. He'd been pink slipped a few times. He was a full-time student at Wittenberg University, and just started having troubles his freshman year, and things just started to escalate, to spiral out of control. In this 1 week, it was particularly very bad, lots of criminal trespassing charges, lots of criminal damaging charges, and just waiting for that phone call to see what was, what has happened and where he was and that sort of thing. He particularly had a really bad day, and he went to the mental health services building, and he started pounding on the glass, and he was upset that he wanted to donate some Bibles and they didn't want the Bibles that day, and he got very agitated and very upset. So he went home just a few blocks away from the mental health services building. The director of the mental health service building called the police and asked that they do a well check on my son. The police arrived at his home. They knocked on the door. Sam came to the door. He had a sheriff's badge on. He had his hands clenched in front of him. And this is everything that I've gotten from the police reports, and also my neighbor that was out on the sidewalk at the time. And he had his hands clenched in front of him. He wasn't holding a weapon. He introduced himself as the sheriff. And then he also, I guess that didn't elicit the response he wanted. So he said he was the president. And the first thing that the officer asked him to do is to put his hands above, behind his head. And when he did not comply to that, the police report says that they decided that they needed to take him to the ground. During this time, he was tased. They sprayed pepper spray on him. They threw him so hard against the door that it shattered the glass all over the porch. During all of this time, there was 3 officers went to the door and more officers arrived at this time. My son bit a police officer's finger that was in his mouth during the altercation. Ended up having a felony for that bite, I guess. My neighbor called me. I was at a conference in Columbus for work. My neighbor called me and said that they had taken Sam away. The issue, the hardest part was, and I'm not gonna, it was kind of a relief that I thought that now maybe he can get some help. The problem was nobody told me where he was. I couldn't find him. So I called the police department. They said they dropped him off at the hospital. The hospital said they couldn't tell me anything because he was an adult. I called the mental health services building and the lady there screamed at me and said he was banned from mental health services building. He was never to come back. And, which and other times I might've thought that was humorous, but, it really wasn't that day. So I couldn't find him. And then I think another day went by and then somebody called me from Springfield Regional Hospital anonymously and told me that he had been taken down to Summit Health down in Cincinnati, where he stayed for 6 months. I think that one of the disappointing parts, other than the police, if there had any police had gone through the CIT training, I'm disappointed that they didn't follow a lot of those, suggestions. After Sam came home, after 2 or 3 months, I started wading through all the court, his charges, and I got to read the police report for the first time. I wrote I guess I wanted to file a complaint with the police department on how it was handled. And I was told that either 60 or 90 days had passed and they would not talk to me about the incident because it had gone past the time period that they would even investigate it. So, and I didn't want anything. I wasn't suing. I didn't want anything. I just wanted to talk to them about what happened and why a well check. First of all, a well check shouldn't start off with put your hands behind your head. And then some other things that, maybe the next person wouldn't have to deal with. But the second incident happened in Thanksgiving of last year. Sam was having, again, a bad day. I would say some hallucinations, a lot of yelling, screaming, couldn't reason with him, manic. And I called the police department, which is a hard call because I'm not real sure that I trust the police department to come and do a well check or check on Sam. But it got to the point we called the police department and they said that they couldn't do a well check. They needed something from mental health services for them to go over and check on him. And so I called mental health services and they told me that since it was Thanksgiving, nobody was working that day and that nobody was able to sign those papers or to sign those documents that he could, get some help. So those are, I guess, 2 crises I could sit here all day and tell you many, many more. I guess I was asked maybe to think of some positive things. I'm not sure that I could do that today. There, of course, have been some positive people in and out of our lives as we've navigated through this system. And usually on days that I feel like we need it the most, both my son and myself. So I guess the best I can do is just to hope that maybe someday, I know there are communities that mental health professionals go with the police officers on those calls. I have a lot of hope for 988. I'm not real clear if the person having the problem is the only one that should call or if a family member can. So I'm kind of interested in learning more about that today. I also think that the CIT should be required for police officers and not just a voluntary course. And not only take the course, but also be expected to do those things that have proven to work during a mental health crisis when it involves a law enforcement. I would like for Clark County to have a task force that maybe would involve family members and those that are living with the mental illness that could be on that task force to kind of talk about ways to ensure that people living with a mental illness don't have to go through the things that my son has had to go through. So I just in closing, and I hope this is appropriate, but a few weeks ago, there's not been a lot written about it publicly, but there was an incident where a young man, it seemed like he was having the same kind of problems that Sam has had off and on. And he ended up shooting and killing the police officer that came to the residence to help him. And there's been lots of things written about the police officer, Matthew Yates, and there should be, because I understand he was a wonderful man and a wonderful deputy and a great citizen of Springfield and Clark County. But the mother went to the residence as well to try to help her son. And from what I understand from family members and other people, that she did ask for help several times for her son and did not get the help that he needed. And she went to the residence, and I know how that feels. I could feel that in my bones when I read that she, the drive over to help her son, I guess the desperation that she might have felt that day, and that she went to the son's home, and he also shot and killed her as well that day. And that just happened a few weeks ago. A lot's been written, like I said, about the deputy, nothing about the mother. And I probably wouldn't say this to too many people, but the young man that was going through, I think, the mental health crisis, I feel what a horrible day for all three of them, just what a horrific day. So I just kind of wanted to give a shout out to Jody Arbuckle, who's the mother that was killed that day, was killed trying to save her son's life. And I just wanted to recognize her. And I don't know too many mothers that wouldn't have done the same thing. So anyway, with that, I close, and I thank you for letting me tell my story.
Thank you, Nancy, and what a powerful story it was. And I really appreciate hearing from you in terms of, as we look for system improvements, what is as the system, things that we might want to challenge ourselves to look at differently, do differently. And that's kind of some of the foundation of the work that we've been doing in the Crisis Academy, trying to look at overall system improvements. So we really appreciate you, and we thank you for being with us today.
Okay. Thank you. Have a good day.
Thank you. So next on our agenda, I'm going to introduce the Deputy Director of the Ohio Department of Mental Health and Addiction Services, Alicia Clark. And Alicia Clark will be introducing her panel, where you heard Director Chris speak on how we are going to highlight the Ohio Crisis Task Force that we put in place, as well as the pieces that will be culminated into the crisis report. So I am going to turn this over to Director Clark, Deputy Director Clark.
Thank you, Fonda. And thank you, Nancy, for sharing Sam's story. Thank you for your bravery in sharing that story today. You are at the center of why we are here today, learning together, because we know that as policies are developed, when there are individuals that are impacted by those policies at the table, those policies are more effective. So thank you so much. My name's Alicia Clark, as Fonda identified, and I am the Assistant Director of Community Planning and Collaboration for the Department of Mental Health and Addiction Services. And thank you all for being here and taking time out of your busy day to join the Crisis Academy. I will be introducing my panel this morning. Our panel is going to entitled the Ohio Task Force Report. And joining me on my panel today, next slide, please, is Chris Villema. Chris is the CEO of Healthcare Perspective. He was recently named one of the top 50 healthcare leaders in consulting of 2022 by the Consulting Report. Congratulations, Chris. He has over 22 years of behavioral health information technology, and health policy experience. Chris has worked in 24 different states with mental health and substance use disorder departments, county boards, managed care organizations, safety net hospitals, large health systems, community health providers, and federally qualified health centers to enact meaningful change initiatives. Prior to joining Healthcare Perspectives, he was the Director of Behavioral Health for Germain Solutions and the first Chief Information Officer for Alabama Department of Mental Health. Next on the panel will be joining us is Captain Matt Parrish. Captain Parrish leads the Division of Fire's outreach programs, where he assists individuals with substance use disorders, cardiac disease, and health resource inequities. His peers say that he epitomizes the definition of public servants, working hard and ensuring that all citizens are offering a non-traditional response to help the most vulnerable in the community. Captain Parrish leads the Rapid Response Emergency Addiction Crisis Team, REACT, which is a multidisciplinary team that connects high-risk opiate users with medical and social services professionals that offer follow-up within 48 to 72 hours. Next slide, please. You know, again, hearing Nancy's story to lay the foundation of why we're all here today. Ohioans are at the center of this work every day for the department and for the governor's office. We're working together diligently to include individuals and families that have navigated our crisis system to help inform our strategies as we move forward together. We have put together a crisis task force that included individuals with lived experience and families of individuals with lived experience. Next slide, please. The Ohio Department of Mental Health and Addiction Services and our partners are continuously working to develop quality crisis response systems that are timely and an appropriate alternative to unnecessary arrests, incarceration, and unnecessary hospitalization, some of which you heard in Nancy's story. Ohio's vision is for every Ohioan to have access to a visible and accessible crisis continuum of services and supports that are person-centered, quality-driven, and focused on ensuring people are stabilized and thriving in the community. Ohio's crisis continuum includes 4 main elements. I know you've heard these before, but we're going to go over them one more time. Connect, a place to call. Respond, someone to respond. Stabilize, a place to go for individuals that need a little more stabilization. And thrive, which is one of our true goals of the crisis continuum, is to make sure that individuals and families that are experiencing a mental health or addiction crisis get connected to the services and supports that they need in the community that will reduce the chance of a future crisis. Next slide, please. This slide shows the value of a full crisis response. The slide is from Connections Health Solutions in Arizona, and it really talks about how a full crisis response will be able to assist individuals in crisis. So on the left here, you start with the person in crisis, and from Arizona's data, they've identified that a fully staffed, trained call center approach can resolve 80% of the crises over the phone. So of all of the folks that were calling into the crisis line, 80% of those crises were resolved over the phone and people were connected to care or resources. Of those individuals that still needed a little more response, their mobile response teams were deployed to go to wherever those individuals are in the community. And they noticed that 71% of those responses, those crises were resolved in the field, which is huge. And then of those individuals that might need a little more support, and those individuals that were going to a crisis stabilization facility, 68% were discharged successfully to the community, which is another wonderful outcome. And then of those that are discharged into the community, 85% remain stable with the appropriate wraparound services and post-crisis support. And so Ohio is setting a foundation to develop similar metrics to tell our own story of the crisis system and the impact of our crisis system as we build towards our Healthy, Hopeful Ohio. It begins with addressing the crisis needs of the community. Next slide, please. So one of the ways that Ohio has begun this work is developing the Ohio Crisis Task Force. The Ohio Crisis Task Force was convened in collaboration with the Ohio Council of Behavioral Health and Family Service Providers, OHCBA, the Ohio Community Behavioral Health Authorities, the National Alliance on Mental Illness, NAMI, community members, partners, sister state agencies, Recovery Ohio. The task force is a streamlining process where we wanted to bring all the thought leaders together that were in the space of planning for their crisis continuum. It is the place where planning conversations emerged and diverse coalitions were identified and developed. And it was the place where innovative approaches and sustainable resources were discussed to enhance Ohio's crisis response system. The task force began with developing a strategic framework for our crisis system. And part of that framework included information and communication with our boards, our providers, private foundations, associations, first responders, justice systems, hospitals, individuals and families with lived experience, so that we can make sure that we had an open tent approach to discussing and designing strategies to develop Ohio's ideal crisis continuum. The initial goal of the task force was to inform the Ohio Crisis Landscape Analysis and Recommendations Report. And so I'm going to turn this over to Chris from Healthcare Perspectives, and he will take a deeper dive for us into the content of the report.
Thank you, Alicia. So we're going to cover today during my segment the how the landscape analysis was developed, the key findings, some of the key findings, some of the key recommendations, and then what's next in terms of the Ohio Crisis Continuum and all of the great work that is ongoing and will continue in coming months and years. So as Alicia mentioned, we had a structure of the task force fed by committees and subcommittees that really developed this landscape analysis. So the task force was the main driver of the analysis, as well as work that we were doing to gather data. Myself and Dr. Minkoff from Zia Partners, as well as the rest of the team at Healthcare Perspective, Hillary Hamlin, Stephen Hedgepeth, Jenny, Cornelia at one point, all assisted with this work. So the task force was considering those recommendations that came up through a process of committees and subcommittees that Matt participated in. Captain Parrish will talk a little bit about his experience of having led a subcommittee, as well as being a key leader for one of the committees. That work was processing the data from a survey that was conducted of all of the boards in the state, as well as data from other sources from the departments, both of mental health and addiction services and also Medicaid, reviewing best practices, talking a lot about some initial questions that were given to each of those subcommittees to kind of guide the discussion about what we were trying to understand about the landscape of Ohio crisis services for people with behavioral health challenges, and making those initial recommendations that then flowed up to the committees, which processed their work and really looked at additional input from all stakeholder groups that were identified, as Alicia talked about, that were part of every single one of those committees. So we made sure to try and have a diverse representation from all of the different segments of the crisis continuum, as well as advocates, people with lived experience, trying to make sure that we gathered as much valid information as we could from everybody that's participating in the system, understands the services that are being delivered and how this actually works in practice. And then those final recommendations were submitted to the task force. The task force considered those and adopted the recommendations that were made by the committees into an action plan that the task force blessed and will be moving as part of what the department is trying to do to develop an action plan to act on these recommendations. And so another thing that came out of the process, we heard a lot. In addition to the committee and subcommittee meetings that we participated in, we also had separate sessions with the different regions in the state, as well as with different sized boards that had like experiences because of either having levies or not having levies, and having more resources versus those that didn't have as many resources, or smaller boards, medium-sized boards, large boards. We also had sessions with advocates and met regularly with the board association, the provider association, met a few times with the hospital association as well. And there were things that bubbled up that we kind of summarized into consensus values and principles that the task force recognized as well, and said, yeah, these are sort of what we are from a values and principles standpoint, and what we want our system to be. So the Ohio's behavioral health crisis system is really designed, and we want a crisis system that's designed for all people in Ohio who experience a mental health or SUD crisis. And what this is specifying is that we're not talking about just people on Medicaid, or just people who don't have any insurance, or any particular group or segment of the population. This is for everybody. We want a system that works for everybody. It may not work in the same ways for everyone, but that there's a system that's designed and set up to address the needs of all Ohioans who are in a mental health or SUD crisis, or people who are in Ohio. As was pointed out, it could be someone from another state who experiences a crisis while they're in Ohio, and you want to be able to address that as well. The crisis system is designed around core values. So we want our services to be welcoming and safe and hopeful and person and family driven and empowering and trauma informed, and culturally fluent. So really understanding that the services themselves need to be delivered in a certain way, and that we have principles and values that we want in the service delivery itself, and want to ensure as part of that process. The crisis system is designed to help every individual and family experiencing a crisis to get the right help in the right place at the right time. And to get that help not only to stabilize, but to thrive. And that's one of the unique elements that Ohio has added, is this idea of thrive, and making sure that people can not just stabilize, but also thrive. And we wanted to incorporate that, and we heard that repeatedly from the stakeholders as well. The crisis system is forward thinking, looking beyond the current service and funding model designs to design and fund services for Ohioans in accordance with our values. So there was definitely a desire from the partners and from the department as well that we look at a different way of addressing these needs, and making sure that we're taking advantage of all of the funding mechanisms and opportunities that are out there. There are opportunities from the federal level, opportunities that the state has with dollars that have come available to think about how we fund crisis services in the state, and how that looks going forward. Crisis system belongs to everyone. It requires collaboration, contribution, partnership from everyone, both locally and statewide, something Dr. Minkoff and I talked about regularly throughout this process. This process would not have been possible everywhere. We've certainly worked in other states and in other environments where there was too much history, too much bad blood, basically, between different partners in the state, and there wouldn't have been the opportunity to work together like we did on this. So we really appreciated the opportunity, and saw that is a value that's held in Ohio, that no matter what challenges people have, they recognize the opportunity here, and they recognize that the need, and want to move forward, and want to find ways to collaborate and contribute their piece of the process. The crisis system should be in parity with the system of services for individuals who experience any other type of health crisis. So we wanted to make sure, and we heard repeatedly about parity and people's concerns around parity, and the existing parity laws maybe not being adequate to really bring about parity in a crisis situation. But we want to think about designing a system that does that ensures that if I have, a heart attack, I'm getting, the same response or the same level of care from my needs if I have a mental health or substance use crisis, so that those things are equally well planned and well responded to and stabilized, and all of the aspects of the continuum are done in a way that is equal to what would happen if I was in a physical health crisis. Ohio's behavioral health crisis system uses data for continuous quality improvement to be in better alignment with the needs of people with behavioral health challenges and the needs of the community. So something that came up also repeatedly was the lack of really good information, and making sure that we take the time to ensure good data collection, that we're getting good information to be able to improve quality. Without the data, you don't have, the ability to do continuous quality improvement. So we're, continuing to look at opportunities, and the department's, investing a lot of time and energy into getting better information about the services that are being delivered for people in crisis and how those services are coming to outcomes, and what does that look like in Ohio. As Alicia pointed out, the data that was collected in the Tucson area in Arizona, they've been able to show, what the outcome was of implementing a complete crisis continuum that really addresses all of the various segments of the need. And we want to be able to do the same in Ohio, but we need good information to be able to do that and to identify where the opportunities for improvement are, where things are going really well, and where things need to be solidified a little bit more. So the landscape analysis itself takes a framing in each of those areas in the connect, respond, stabilize, and thrive arenas, and a number of other additional segments that were identified as needs and things that needed to be looked at. We tried to address it from a perspective of where is Ohio now, where does Ohio want to be, and then what are the steps that it's going to take to get there. And so you'll see that repeatedly in the final report. But I did want to kind of allude to a few things today and talk a little bit about a few of the findings, as well as the recommendations. So when you think about findings and recommendations in this framework, the findings really were the answer to the where is Ohio now question. And the recommendations were, where does Ohio want to be? These are the things that we want to strive toward. And then there are steps laid out in terms of what some of those things might look like from a more action-oriented process as well. But I'm going to stick to the findings and recommendations today and really talk about where Ohio is now and where does it want to be. I'm not going to talk a ton about Connect because we have our experts on 988 on here as well, and they have their own session. But just from a high level, we looked at it beyond just 988, understanding that there's almost total coverage across the state right now for crisis lines, hotlines, and warm lines. That's something that you have a really strong basis to build from, as well as having more of the NSPL call centers than any other, and now Lifeline call centers, however you want to term them, more than any in the country. So you have a base of resource from a call standpoint and a text and being able to connect people. You have a pretty deep and wide access to call centers. People have the ability to call someone in every part of the state for a variety of different things, not just for crisis. But where does Ohio want to be? You want people to be able to utilize 988 as the go-to, and again, this will be addressed more in a later presentation, for mental health and SUD crisis. You want there to be an interconnected response between 911 and 988. So when Director Chris and Deputy Director Clark talked about, we're doing work that not every other state is doing, what I am seeing is some of that happening in other states. There are RFPs and projects that are ongoing that are just dealing with this connection between 911 and 988. I've seen several in recent months of states that are really trying to address that need of how do we ensure that 911 and 988 work together, and how can we develop a plan, and even large counties that are kind of thinking about that approach. Consistent performance metrics and sustainable funding are needed for 988 and the connect piece of the crisis system to really work well. Making sure that we have those pieces in place going forward. Respond. Under respond, someone to respond. Where is Ohio now? Obviously, MRSS has been an extremely important step in the development of both a model that could be used for other situations and other populations. So going through that process is something that will be valuable to looking at other populations. But recognizing that that's for children with Medicaid that have that funding mechanism to deal with mobile response. But that is a model that is in place in Ohio. There was a lot of work put into it. There's a lot of good work going on, and as well, there will be a presentation on that later in this session as well. Many counties have some level of mobile response through a variety of different mechanisms, including some partnered first responders. I think that was a learning for us, and I think a learning for the larger group as well, that there's quite a bit of mobile response going on, but it's just more in pockets and in different structures and models that work for different places and that came up and bubbled up for different reasons. So when we think about opioid response and issues around opioids, you can think of teams that are out there and have been developed to deal with opioid response. Well, maybe we can broaden that to be more than just opioid response. I'm having a tough time with that word today. But other mobile response models, and we put an emphasis on the definition of mobile in our data collection around anything that was going to the person. So someone to respond, when you think about that from a broad level, it really is anything that's not, I'm sitting in an office or I'm sitting in, a facility and somebody has to come to me. The respond piece is anybody that's going out into the community, whether they're doing assessments in jails or whether they're, working with individuals in the home, whatever that response is, there can be a pretty broad array of services and types of models that could all be response to a crisis. It's a matter of how are those connected to the first step in the process, how are people aware of those services and knowing which ones to route when, and what the timing of those need to be, how quickly they can respond, and how active and robust those services are. So we've talked a lot during the committee process work that there are lots of services that are available, but they may just not be as robust or widespread as needed, and they may not be as connected to an overall plan of crisis services. They may have bubbled up out of a particular need, but not looked at as an overall piece of the crisis continuum. It was more of we're responding to this particular need, trying to address this particular issue, and developed a response for that, but we don't have a general response for mental health and substance use crises. So where does Ohio want to be? You want to have those mobile crisis teams, including clinicians and peers, available for adults and for kids 24/7 everywhere in the state. I mean, this is a pretty straightforward goal. It's a lot less straightforward getting there. So where do you want to be? You want to have that robust response for anybody anywhere in the state. How do you get there is the real challenge and issue. And there may be a lot of different ways that people come up with to be able to address that need, and particularly in rural areas and areas where there's a little bit more of a challenge just getting to people, but understanding how to do that and do it in a way that is robust, but is also feasible and manageable within the structure and the funding that's available. The behavioral health urgent care walk-in services being available for after-hours response statewide. So we categorized behavioral health walk-in services under the respond as well, because we also don't just want services that go to people. We also want services that are available for people to walk into when that need arises and when it's more appropriate for them. They're not going to necessarily call ahead. They just want some place to go and be able to get their response there. So behavioral health urgent care walk-in has already expanded even over the course of the development of this report. There were new centers that opened. And also since there are new urgent care types of services. Now, the other thing to understand about all of this is that there's the possibility of putting services in a single center, and talking about a crisis center that has the response team housed in it, that has the behavioral health urgent walk-in care services, that has some of the stabilization centers that have been established in the state have several of these types of services as part of their overall service delivery model. So you don't have to think about them as separate services that have to be separately stood up and separately managed. It could be one center that does all of these for a county or a region. In terms of stabilize and a place to go, there's been significant investment in crisis stabilization centers. So that's recognized, and I think people understand that there have been dollars put toward the concept of crisis stabilization centers, and there have been new centers stood up. There have been new services stood up all over the state because of those dollars that have been invested. There's significant geographic coverage that's provided by those existing and planned crisis centers. There's still a couple more that are on the books to be open soon. So that's a great place to start building from for a stabilize and a place to go, that there are centers that already exist. There are beds that people can access today in certain areas of the state, and they have pretty broad geographic coverage when you look at where they are in the state and what counties could be reachable from those centers. So where do you want to be? You want the full array of services to scale, either in every county or in a county nearby. We recognize that, some counties are just too small to manage, an entire array of services just for that county, but you want the people in that county to have access to the full array of services in their county or in a county nearby. Crisis centers that are fully able to serve involuntary and voluntary clients. That was a challenge that we talked about a good bit, that even though there may be beds, there may be places for people to go, a place to go, they may not be accessible for every type of individual. And this is a challenge that's faced everywhere in the country. It's not just in Ohio, that it's more that there are more options for people who are voluntary versus involuntary, and for people who have less complicated medical issues versus those who have more complicated medical issues. This is a constant issue and challenge that communities need to work through, as well as at the state level. But it really is a community by community issue, because you may have resources, you may have beds, but you may not have the staff to manage, or believe that you have the staff to manage involuntary folks as well as voluntary. Partnering with hospital systems to include hospital-based crisis services in the planning continuum. So you have a lot of hospital resources in the state of Ohio, and that's something that needs to be leveraged as part of this component of the crisis system, and all components of the crisis system, but particularly here when we're talking about stabilizing people. How do you work with the hospitals to ensure that people are being served in the right place at the right time with the right services? That's really the framing and the discussion you want to get into, is how do we ensure that, we're dealing with every individual that needs services in a way that's most appropriate in the most appropriate environment. So there may be, cases today where a lot of things are being dealt with in hospitals that probably is not the most appropriate environment, but it's just where people end up. And that's what you want to try and, facilitate as a community planning process, is how do we ensure that people are getting the right services in the right places at the right time? And a lot of what's going on now is not in the right place. And how do we create the right places? How do we ensure that people are getting to the right places for those services at the time that they're needed? Thrive. MRSS has been really important in ensuring that, I apologize, I think I did not update this slide. So I'll talk about Thrive off the top of my head. So Thrive is really about, what we found is that Thrive is a lot of what's going on in the community is really strong. And you have a lot of opportunity to connect people with services and ongoing care. And so OhioRISE, MRSS services, all of the new initiatives, there's a lot of opportunity to connect people to the ongoing care in the community that they really need. And so ensuring that going forward is expanded, and that people are understood that just because you got to stabilization does not mean that you're able to thrive, that just getting somebody stabilized is not the end of the process. And so looking at the broad continuum of services and all of the things that are out there, again, there's a lot of really good work going on and a lot of really good services across the state, but it's spotty and piecemeal in terms of why it came about or for what purposes it is, whether it's transportation or whether it's education and employment services or whether it's housing. There are initiatives that are out there that have done great things, but they're not, statewide initiatives. They're not, the same in every community, and they haven't been brought to the same level in every community. So looking at what people have been able to do successfully from a housing standpoint, from an employment standpoint, from a transportation challenges, those kinds of things are desperately needed and are also being successfully done in many communities across the state. And so where you want to be from the standpoint of Thrive is you want to be able to connect people to all the services and all of the needs they have throughout this cycle, and making sure that you're not ending with, okay, we got them through this crisis. Now we're done. We want to make sure that those connections are made, those needs are met in every way that we're capable of, and that the community is capable of as a whole. So this is not just being taken on by the provider of mental health or substance use services, that the entire community is helping and assisting and using the resources of all the various aspects of the community to help people thrive. So with that, I will turn it over to Captain Parrish to talk about his experience, and then we'll have some time for questions.
Good morning, everyone. Like Alicia said, my name is Matt Parrish. I'm 30 years with the Division of Fire here in Columbus. And when Alicia and Director Chris asked me to be a part of this task force, it was really quite an honor and something that I've been working on throughout my career, because we recognized as first responders, often we were called to calls that we didn't have the right training or the right resources to manage and to get the individual connected to the right care they needed. And by default, we took folks to the hospital. So it is quite an honor to be a part of this group and a part of this work. And for me personally, as an individual with lived experience of family members that have dealt with SUD and mental health, Nancy's story this morning was really touching, and something that I've experienced on the other end as a first responder responding to calls, and understanding that we were not the right resource that needed to be called for those calls. So, personally, it's an honor to be a part of this, but it's also something that I've been very passionate about, and not really a new concept. I think, fire departments in the EMS have, if you look at the 4 continuums in respond or connect, respond, stabilize, and thrive, that's basically what the 911 system is, right? There's a number to call, there's 911. We have the ability to respond, we stabilize the incident, and then we connect people with recovery resources so they can thrive. So I felt like I also brought a lot to the task force in that we have had the infrastructure to build out a mental health mobile or continuum. And obviously my expertise in this was in the respond part. About 10 years ago, when the fire departments and EMS agencies started to get into community paramedicine, I started using the mantra, change the number or change the response. We were getting called for calls that we weren't necessarily the best equipped to manage or didn't have the resources for individuals. So when 988 was mentioned and the work began on that, it was also something that really played into something I had been looking at here personally in Columbus and where we wanted our response to go. Locally here in Franklin County and Columbus, we've been collaborating with our mental health providers and the local AdamH board for many years now. 5 years ago, we started our first co-response teams. the REACT team, which was heavily focused on the opiate epidemic, and also the SPARK team, which deals with social determinants of health and mental health issues. And then I helped Lieutenant Jeffrey at the time with our police department start the MCR, built upon the REACT model. And you know, like I said, we've got the we had the capability to get a call, to respond and provide a different resource or a more appropriate resource. And going forward, we've also realized, you know, often we are the last resort. First responders get called because we had the number that everybody knew to call and nowhere else to turn. The mental health provider wasn't open. It was a holiday. Somebody needed to do something, so they called us. And, you know, we just didn't have the right training or the right resources to dispatch. And now we've built some of that out. But to take that even further and kind of go along with what you'll hear about with 988 is we created a right response unit in our radio room. So we can triage those calls more appropriately and determine what is the appropriate response piece. So my role with this task force was in the respond area, and specifically I chaired the mobile crisis response piece, and really helping to share some of my experience over the years of, and most recently the last 5 years was working with multiple agencies. And there's so much that goes into that as far as different protocols, different scopes of practice, just different capabilities, different work schedules. And it was really a great collaboration between all of the committee members and all of the partners involved to share what they've done locally in their communities and really try to build a model that isn't too rigid and has the ability to be flexible based on the local needs. You know, anybody's heard me speak before knows that I love to use humor to really explain. And one of the best quotes was like, you wouldn't call the Coast Guard if you fell in a puddle. And we don't need to send law enforcement and fire and EMS on calls that require a peer or a peer and a clinician. So, you know, moving forward, I believe there are multiple models that can work. And that will be more effective and really deliver that right help at the right place in the right time. The collaborations with this task force, you know, for as bad as COVID has been, I truly don't believe the work that has been done could have been accomplished had we not learned how to use the virtual platforms. We were, over a course of a year or less, we had representation from all over the state, multiple committee meetings, multiple subcommittees and work groups that were able to get work done virtually. And, you know, prior to the use of the virtual platforms like this, that work would have been delayed and slowed. So it's really been a great honor, and I'm excited to see where this can go. I'm really excited to see how 988 will impact the work moving down the road. You know, at the end of the day, when you ask my firefighters, they want to respond to house fires and heart attacks and the calls that they've been properly trained for and get to use their skill sets. And we want the properly trained clinicians and peers and mental health providers to be able to respond to this work and making those collaborations. So that's been my experience. And again, I think there's a lot of good work going on out there. There's a lot of great work going on here in Franklin County and in Columbus and locally. And it's been great to connect with folks from all over the state and learn from them and really build that whole continuum of care and collaborate. Because again, when I take my uniform off, I'm a member of the community. I'm a member of the community with a lived experience. My family wants me to come home safely as much as any other family wants their family members treated safely. And the only way we're going to do this is by collaborating and working together. So I appreciate, Alicia, I appreciate the chance to present here and share my experience, and happy to answer any questions.
Thank you so much, Captain Parrish, and thank you so much, Chris. This just shows just a taste of how robust the Crisis Task Force is. We are lifting that task force back together so that we can continue this work. But we want to thank all of the participants that participated on the task force. We had, as we said before, law enforcement, hospital systems. There were individuals that lived experience in their families, and all of our associations came together. And I will say that Chris and his team reminded us all the time that Ohio was one of the states that they had no barriers coming together and working together. And that was a testament to all of you on the call. So thank you for that. There were a couple of questions that were answered, but one question that I see is around the data that we shared for Arizona. That is the latest data that we have, but currently right now, we have a community planning process that's underway that our local ADAM boards are in the middle of navigating. And that process includes information on the crisis system. So there'll be a set of information and data sets that are included in the report, the landscape analysis report, and then we're getting updated information from our local system currently on those metrics. So Ohio will have as much as updated data as we can provide, and as soon as the report is available, we'll be happy to share that with this team and everyone who's interested. Are there any other questions that I may have missed? I'm looking through. There were some great questions around partnering with individuals with pregnant mothers and individuals experiencing postpartum. And I responded in the chat that we do partner with the Moms Project, and I put the website in the chat for everyone to visit. And so that's a great question. Thank you for bringing that population to the top of our minds again. We also had some folks that were very interested in joining this task force and joining some of the work that's going on underway in the crisis space. And we want to thank you for that. Our representative from the state perspective is Sharon Fitzpatrick. She is our peer lead for the state of Ohio. So if you're an individual that is an individual with lived experience or one of our certified peer supporters, please communicate directly with Sharon. She can help you get connected to the work that's underway in the department in crisis and other areas. Was there any other questions that we may have missed, Melly?
We're looking through the questions and answers now. We've had a couple questions about the PowerPoint. We'll be trying to collect PowerPoints, and we'll be sending all those available out after today's webinar. The webinar is being recorded and will be available on the Ohio Department of Mental Health and Addiction Services website. So you'll be able to have that information once that's uploaded. There is a question we just received. Has the task force taken into consideration obtaining information from families when going out to see a person if they have history of alcohol and drug, which we know can contribute towards the behavior?
Let's repeat that question one more time, Elijah.
Yeah, that's a big question. Has the task force taken into consideration obtaining information from families when going out to see a person if they have history of alcohol and drug, which we know can contribute towards the behavior?
Mm-hmm. So the task force is made up of stakeholders around the community that work together to help inform the policies that are developed around the crisis system. But included in that task force are many providers around the state that deliver direct services to the individuals experiencing a crisis across the state. And so those providers would be the ones that would go out and canvass the questions from the family and look at all the information around the treatment planning for that individual that's in need, and connect that individual to the best level of care possible. Thank you for that question. Great question. Well, with that, I want to thank my two panelists. They are absolutely just leaders in this space, and we want to thank you both for being able to support the Ohio Crisis Task Force and support the Crisis Academy today. And thank you, everybody. Thank you, Elijah. And we'll move on to the next presentation.
Once again, thank you, Alicia, Chris, and Captain Parrish. So our next presentation, and I'm going to ask Chris, okay, the screen is coming down now. Our next presentation is going to be on 988, and I'm going to introduce Doug Jackson, who has recently started with the Department of Mental Health and Addiction Services, where he serves as the 988 and Mental Health Administrator. Doug is also going to be introducing his panel. So I'm going to turn it over to Doug now.
Well, thank you so much, Fonda. Happy to be with everybody today and happy to be part of a panel that's going to be discussing 988. Really, I think what Fonda accomplished was passing off to me the introduction of some very long or difficult to pronounce names of my panelists. But this group of people is a fantastic representation of the collaboration in Ohio that is rising up 988 and has been a part of it through the development and continued through its current operations and looking to the future. So with me today is also going to be Stacy Frohnapple-Hassan. She also works for the Ohio Department of Mental Health and Addiction Services as the chief over the Office of Prevention. We also have Vince Brancaccio, the Help Network of Northeast Ohio. Vince is the chief executive officer there. And Dwayne Piccarelli from the Mahoning County Mental Health and Recovery Board. So you can just see from the names on the screen and the places that are represented here, a collaboration in one style, but the collaboration has been much larger than just this. But it's great to come together with some key stakeholders as we talk about our launch of 988, what happened to prepare us for that launch, and also how we're doing now and looking to the future. So that's really the panel's focus today. As we look at 988, Captain Parrish, I hadn't heard that quote yet, but the quote that he repeated today, he said he's quoted it many times, was a fantastic quote, and that was change the number or change the response. When we look at what it would be to change the number, prior to 988 existing, 911 was the number. So let's just pause for a moment and look at 911, its history, its service. So 911 was actually suggested in 1957, and it was by the Fire Chiefs Association. It took about 10 years for the FCC to recognize the need and actually designate a 3-digit number for emergencies. That 3-digit number became 911. So in 1967, 911 came into existence. But from 1967 to 1987, 20 years, it took for 911 to become available to about 50% of the United States. So 20 years to rise it up to a usage possibility of 50% of the United States. 988, much different. Now the time is different and the speed of business is different, technology is different, but 988 had about 18 months to go from the federal requirement for each state in the United States to launch 988 until the launch date. 18 months to put together not only a number, but all of the background behind the number that would help to answer the call and be ready to share necessary resources and have interoperability with other responders as well. So the lift was huge. But I'm really happy to report that Ohio has again led the nation in the way that we have brought 988 to our state residents. When we look around the nation, we have kind of a spectrum of how states have responded to this. Some states have become ready more robustly and more quickly than other states, but Ohio has been looked at as a model state of what we're doing for 988. We participate in many national conversations about how things are happening here in Ohio. And you'll hear today why that is as we look to the collaboration between the stakeholders here. So I'm gonna introduce Stacy to begin with just a little bit of background on the stakeholder involvement and the pre-launch planning. Stacy?
Thank you, Doug. we knew that we would be pulling this group together in December of 2020, but the 988 Planning Committee first met in February of 2021. And our charge at that point was to plan and implement 988 in Ohio. We needed to do this in a relatively quick amount of time. We had 12 providers at that time, and they were only serving about half of our counties. But a little bit more about the Planning Committee. First of all, to all of those representatives that are on this Crisis Academy, thank you. Thank you so much for giving so freely of your time. And many of you then continued to give of your time for the Crisis Task Force. But the Planning Committee met for almost 18 months. We had about 50 people engaged in that group and additional folks totaling around 100 involved in the 6 Planning Committee work groups that we had. And those individuals were from the behavioral health system of care. They were from mental health and recovery boards. They were behavioral health providers. They were our call center representatives across the state, especially the current 988 call centers and some of the ones that were pending with Vibrant Emotional Health, the national SAMHSA, the federal vendor for the National Suicide Prevention Lifeline. We had representatives from the 911 system and first responders, such as Captain Parrish and colleagues of his. People with lived experience were very key in the Planning Committee. We had individuals from diverse cultural and ethnic backgrounds and groups. Those contributions were incredibly helpful, and some of the marketing work that happened over the last 18 months will start to come into play even more as we look towards a larger statewide campaign. That was, we consider it a soft launch, this current first 6 months of 988 being live. We had members of the military, both in-state from the Governor's Office of Veterans Affairs and also the regional VA folks. Tara Consolino was part of our group. State leadership at many levels and members of the Ohio General Assembly. And I'll stop there because there are so many groups, it's hard to mention them all. But it was an incredibly helpful and outspoken bunch of folks from the constituencies for Ohio's crisis system. As you've probably heard by now, we did start with the 12 call centers and half of the state being covered. And by May of 22, we were able to expand that coverage to all 88 counties. And as of today, the 19 call centers that we have active with the Lifeline are all 24/7, all 3 shifts, 24/7, 365. So we're very pleased with the coverage that we have in place. And with that, I will turn it back to Doug.
So 988, as we know, is the entry point into the continuum of care that the previous panel had already discussed. The idea that 988 is being used to connect is an important part of that continuum of care, for people to have a number to call. As Stacy has pointed out, the collaboration has happened with existing call centers that were already providing a service through the National Suicide Prevention Lifeline, and then additional call centers that became certified through NSPL, National Suicide Prevention Lifeline, to also provide that service, making Ohio have 19 call centers that were answering the 988 calls. So to put that in perspective, each state has organized their call center response differently. But Ohio has the most number of call centers in any state, 19 being the highest. I believe the second highest has 14, and it goes all the way down to some states only having 1 call center covering the entire state. Why did Ohio do that? Well, Ohio did that because as you look at this continuum of crisis care, Ohio is built on the principle that the local resources, the local providers provide the value in the local community. And so we worked with many stakeholders and making sure that we were ready at a local level. Now, I say that because we're getting ready to also hear from a county board as well as a 988 call center provider. But let me first explain how this stakeholder group has worked together to provide the 988 service. There is 3 tiers prepared to answer call, 3 tiers of call centers. The first one is a primary call center, and the calls are currently being routed by the area code of the caller. Now, we realize that's created some concerns about where the caller is calling from versus where their area code or their phone originates from. That could be different. But what we want to do is also let people know that all call centers across the nation are prepared to answer 988 calls. So you're never going to get a wrong response, but our goal is to have a local response. So we have primary call centers in local communities. But if the primary call center doesn't answer the call quick enough, maybe they're on other lines and aren't available to answer that call, we have a backup to each call center. The backup would be another Ohio call center. So that's a 2nd tier level of support. Still within Ohio, we have a 3rd tier of support, and that is a statewide backup. So in Ohio, we have a 3-tier system assuring that Ohioans are getting a response from a 988 center in Ohio. Now, occasionally a call will go outside of the state. Same for other states. A call from another state might come to Ohio. That is because our response is so dedicated to speed through the national network of 988 centers that we want to assure callers get an answer as quickly as possible. So rolling over from a primary to a secondary to a statewide backup, and then even at a 4th level, a national backup could happen simply because we're so focused on providing a quick response. So on July 16th, Director Lori Chris and others from Ohio Mental Health and Addiction Services, we were out at call centers making sure that calls were indeed coming in. So happy to report that on July 16th, calls were rolling into 988 call centers. Truth be told, they were rolling in prior to July 16th because people had heard 988 was coming, our technology was in place, we were testing systems. But on July 16th, we launched, and happy to report that it has been a successful launch. So how many calls are coming into Ohio? I'm just going to share one statistic with you. I think that this statistic paints a picture, and that is looking at from a year ago, August 2021 to August 2022, and what happened in that year. So this was pre-launch to just after the launch of 988. There was a 109% increase in calls coming in through the National Suicide Prevention Lifeline, NSPL, in Ohio. So in August of 2022, 988 call centers in Ohio answered 6,557 calls. That is a tremendous amount of calls being answered, but it shows the need. And we're going to talk about why it's important to understand what the need is in Ohio as we look at the services that follow a crisis call, the support services that are there, as we look at funding and other things throughout the rest of this panel. A few other statistics. We have an average answer speed of 26 seconds here in Ohio. It's a pretty quick average answer speed. So we're going to be talking some with a call center, starting with Vince Brancaccio joining us. And Vince, let me bring you on so that you can help us talk just a little bit about what your 988 call center is experiencing as you're answering 988 calls.
Very good. Thanks, Doug, and thanks for allowing me to be on this call. I really appreciate it. So in regards to Help Network, so far the implementation has gone smoothly for our agency. We've had a very slight increase in calls, but since our launch, one of the things that we were really focused on was increasing our answer rates on the 988 line. This past spring, we made a conscious effort to increase our answer rates on the NSPL line, with the challenge being given to the providers to get to an 80% answer rate by the time of the launch of 988. I'm proud to say that we not only achieved this, but actually had a 100% answer rate for August. I want to speak to the why. I think, first of all, we were able to achieve this because we worked with Vibrant to change their call routing so that we're only getting calls from the counties we cover, which is Mahoning, Trumbull, Columbiana, and Ashtabula counties. They were able to do this. And right now, looking at our stats, 85% of the calls we receive on 988 are from the counties we cover. Of the 15% of the calls that we get outside of our coverage area, only 5% are out of state. Second, we looked at staff levels and added a few additional staff, with also the addition of new staff. Hopefully in the next week or so, we're doing another round of hiring. The other thing we looked at is the types of calls we were getting after hours, because we were getting inundated with a lot of after hours calls from some of our provider agencies who were switching their phones over to us. And we looked at what types of calls we were getting, and did they really fit our mission and what we do in regards to Help Network. What we found is we were answering to say they were closed. We were answering to say, this is the time they open again, or they were trying to cancel appointments, which is really not what we're about. We're a suicide crisis hotline. We are a 211 INR provider. So we worked with the providers in our area to look at their phone systems, add prompts, and basically say, in this situation, this is when you hit this prompt for Help Network. And with that, and the cooperation from our provider agencies, that helped immensely. And so those calls decreased, which in turn freed up our staff. I think overall, the state has done a great job. Ohio's done a great job. As Stacy mentioned earlier, we started these meetings last year, and I was part of the state implementation team. Me and one of my colleagues, Kristen, who might be on this call, we were representing our 19 suicide hotlines, as well as the 14 211 providers, because we have what's called blended agencies. So we do both. Of those providers, only 4 in the state are blended agencies. I also want to say I participate on a national committee of 211-988 providers who are blended agencies like our agency. I have to tell you, I was on a call last week in Ohio, and Doug said this earlier, we are so far ahead of many of the states in implementation of 988. And that's all I have, Doug.
Thanks, Vince. I really appreciate your comments from the perspective of a 988 call center. It's one thing for a state agency to be able to say that, but when you can say that hand in hand, arm in arm, walking with stakeholders, what an important message that is. And we're going to continue the talk about that as we look at, Vince, what you've done in some local collaborations, and then we're also going to transition from Vince, you, to looking at some input and feedback from a county board that you're partnering with. So Vince, the stakeholders that you have, who are those stakeholders, and what does that collaboration look like for you?
Well, our biggest stakeholders are our mental health and recovery boards, who provide a majority of the funding for our suicide crisis hotlines. So in short, given Help Network's longevity of working in the communities we provide services, which has been over 50 years, we've developed strong relationships with our mental health and recovery boards. Our board directors, they've worked with Help Network to ensure that we have the supports that we need to provide the services. And I think most importantly, during this 988 implementation, the consultation that these mental health and recovery board directors have provided, as well as the promotion of 988 and how Help Network is the agency that's providing the service in their communities, has also been helpful. I think, some people may be aware that there's a social media, things are going out in social media saying that don't call 988. They are not helpful towards maybe the minority communities or LGBTQ plus communities. And they're going to send out law enforcement, which is something that was spoken about earlier. And these individuals are going to get pink slipped. And I think what's important is that we're saying, hey, look, Help Network is the agency that's answering those calls. And Help Network is the agency that's been providing this service for many years. think the other thing that's helped is our mental health recovery board directors have done interviews on our local news stations. They've done interviews for print media, as well as speaking in the community, educating people as to what 988 is. I've also done that. Regarding 988, the board directors have made themselves accessible when I had to consult about 988 and implementation in their counties. They've been supportive financially to us by ensuring we have the funding needed to provide the valuable services we provide. And Dwayne, who's going to be presenting next, has been a big support, and especially to me, because he has an extensive experience with the suicide crisis hotline. He was the former CEO of Help Network when it was Help Hotline Crisis Center. So I've used him a lot for consultation and just kind of relied on his experience in this area. And with that, I want to hand it off to Dwayne.
Thanks, Vince. And Dwayne, thanks for joining us. The collaboration that Vince is talking about is another great example of stakeholders working together. Dwayne, with the Mahoning County, let me turn it over to you and just ask, from the county board perspective, how has the work been going, partnering with Help Network and launching 988?
Well, thanks, Doug. And first, I wanted to say thank you to Stacy, because I was on the original call representing the county boards when this all started, and it was such a big group of stakeholders, and I thought this overwhelming task is never going to come together. So the fact that we're here today and so much has happened is really speaks well for her pulling us all together and everybody working well together. I know there's still challenges, but I think we're far ahead, as everyone said in their states. Just to let you know, I think hotlines are a unique service in all the county board areas, because it's a service where it may be the first time somebody calls. It may be someone that knows nothing about mental health services. It's also the service that our most chronic our most chronic people use. So you have people new to the system and people that may be going into the state hospital using the same service with the same callers. So it's just unique. And I think the crisis workers are truly our frontline workers. Now, Mahoning County, as Vince said, is unique because we were a crisis line, a 211, and a lifeline before 988 came. So we didn't face some of the challenges that the other boards are facing, but I think the fact that Ohio's home rule and the local boards are well established, I think we're going to be fine. I just want to talk just real quick about, when you work a hotline, and I work the hotline, people call, and we realize, and we found that many people visit their doctor weeks before they attempt, because they want to live, they want hope, and that's why they call the hotline. And this is the very core, I think, of our board and our safety system. So I'm just so thrilled that the 988's involved. And I've worked the hotline, and anyone that's worked the hotline, the moment you pick up that phone and you hear that deep breath, and it's coming from the very soul of the person. They're in pain and they want help, and that's why it's so important that we have the system together. Now, the one thing that we do as a local board here, and I think most of the boards do also, is there are no wrong numbers. And I believe that. So you can call 988, or you can call 201, or you call one of the agency providers, or you call the board. They'll connect you to the right source. And the right source might be 988, it might be another provider. When you started, Doug, I told you the story when I first started at the hotline. I called a number by mistake. It was a church. And when I said, I'm sorry, I have the wrong number, they said, no, you don't. And I never forget that. And I tell all our providers, and they do that, is we don't ever say we can't help you. What we say to them is, we may not be the place, but we'll find you a place. So I think that's so important. We've partnered with Help Network, but all of our agency providers and NAMI to kind of create the safety net. The challenges that we're facing right now is that we know there's not a resource directory yet, but the Board Association has provided all the call centers with a list of resources, and we'll continue to update that until a directory is in place. So, just when this all started and Stacy kept saying it was a year away and it sounded like forever, this is coming in July and we're going to do it. Well, I'm here to say, and the boards are ready, 988's here and we're going to make it work. So, you know, we're excited and things are going to happen and we're going to save lives. And that's what it's all about.
Well, thank you, Dwayne, for pitching in and really talking about how your role in 988. 988 isn't just about call centers. 988 is about the whole community of practice here in Ohio working together. And so as we look at that, it's a great time to transition. Give me just a minute to pull up my screen and I'll share another slide with you. The community of practice that we have is all 19 of the call centers in Ohio gathering together twice a month, more as needed. And that's the formal gathering. That's lines in Ohio that are not 988. They are the local numbers. And we have said throughout the launch that 988 is not taking away any other number that is available. So as local numbers are there, we have encouraged boards, providers, anyone who has known that number already, the 10-digit number for a local hotline, you can continue to use that number. But what we heard loud and clear from many, many testimonies throughout the state, and I'll never forget one that I heard from a father whose son had gone through a mental health crisis. He said, if I would have known the number to call, I would have called it. But in that moment of crisis, looking up a number, looking for resources, wasn't what he was capable of doing at that time. 988 is an easy to remember number, and we want it to become that number that people remember. So as we look to local call lines working together with 988 call centers, it's important to have that collaboration. And so we are working with those local lines to begin that collaboration on a broad level for the state of Ohio. And one of the things that Dwayne mentioned was the resource directory. And we are going to be working on that resource directory, or we are working on it right now, to make that available to the 988 call centers, to all call centers throughout Ohio, as well as any other provider and or the general public that can get on a website and look for local resources. And this will be a one-stop place for them to be able to do that. So I'm going to talk just a little bit now with Stacy, have Stacy share about the funding that's been made available for us as we've tried to lift 988. Stacy, you want to talk a little bit about our funding?
Thank you, Doug. So on the slide you see in front of you, we did receive a $3.3 million grant over 2 years to help support Ohio's 988 capacity and to support us as we build out even better quality improvement and quality assurance standards. Even before that, and that is a 2-year grant, even before that, Director Chris committed to fully funding the 19 call centers and our 988 system in Ohio in this first 18 months. So that was the 6-month lead up from January to June of 22, and then the go live in July and through this current fiscal year. And that was a little over $20 million. And those funds continue to go out. And that's easier said than done. Just to give you some semblance of what that looks like, we have grants connected to the $3.3 million SAMHSA grant. We have mental health block grant funds in part for both fiscal 22 and fiscal 23, COVID block grant funds, and ARPA funds. The nice thing with ARPA funds is that they will extend past June 30th of 23 if they do extend past that date, because we know some of the call centers will utilize them fully this year and others may be able to stretch them into future years. All of the funding is absolutely crucial, and we had an exhaustive process with the planning committee and leadership to determine what would be needed in that first 18 months. That included working with actuaries to determine what human behavior would look like in the launch of 988. In other words, how many folks would transition to making a call to the 988 call center, what that increase would look like. And you saw from Doug's slide earlier that we'd seen 100% increase just from last year to this August. So that doesn't even touch on, that's 2 weeks of 988 live, and we still saw a little more than 100% increase. So all of our estimates are an increasing need for funds. They absolutely must be sustainable funds. We've had a lot of, when I mentioned planning committee members, we also had the Telecom Association listening in with our planning committee meetings, public meetings, because there's a lot of interest in potential phone fees. And we know that that's how 911 is funded, and Next Gen 911 will be funded. It would appear, with an increase in phone fees, which would still only take that to about 75 cents per phone per month. So we'll see what happens, but the General Assembly is very interested in how Ohio reaches that sustainable funding level for 988. They're very committed to working towards that, as is Governor DeWine and the leadership team in the administration across the state. And I know that everyone on this call is, and certainly the boards, the providers, our 988 call centers. So it takes it takes a village. In this case, it takes a state working together and advocating in the same direction for that sustainable funding piece for this entry point into the system of care.
Thanks, Stacy. So Vince, let me turn to you and ask, the funds that have been channeled through the state and out to call centers, it's been a part of capacity building. So you knew that you had to have some additional staffing resources to be able to handle the additional work. Talk to us a little bit about what that hiring looked like for you prior to 988's launch and preparing for the launch.
Yes, thanks, Doug. I got to tell you that additional funding has definitely helped us. We were able to increase our hourly wages, get our staff, and get the starting salaries more to a living wage, which has obviously helped in recruitment and retention. At the beginning of this year, we were really having a difficult time in recruitment. First, I think it was our starting hourly wage. And then second, just the climate around the country and workforce shortages. We've had more success in the spring. We did some more, put out some stuff on Indeed and Handshake. Handshake is what the universities use. And we received a lot of resumes. And the problem is, we receive these resumes, but then when we called them to schedule interviews, some of them didn't even know the job that they applied for. And then once we told them what the job was, they're like, nah, I don't want to do that. But in the spring, I want to bring this up as an example. We had 10 candidates that we offered. Of the 10, 5 said, yeah, I want to come in. We set them up for the first day of work. The 5 that were scheduled to start were supposed to start for the training. 2 end up no showing. The 3 that did start, the 1 person opted out after the first day. And basically he said, this is not what I expected. This is a very stressful job. It was ironic though, because he was a vet and he had a pastoral background, which kind of caught me by surprise. But I think it has to be understood. This is challenging work, and you have to be a special person, especially to work with people who are in despair. And so, that person that comes here, and I use that, they have to be special because they have to be able to have that empathic responses, be compassionate, but also understand they have to use best practices to intervene, which is important to the job. You know, not anybody can just get on those phones and just talk to people. You know, you have to have specific training. And so these are professionals. In regards to retention, again, the funding has helped immensely. We were able to increase those hourly wages of our existing staff. This improved morale within the department as well as retain them. We've had little to no turnover, and we're exploring retention bonuses. However, we have to be creative since we have other departments, other programs. We need to make sure that it's equitable. So yes, that funding has helped immensely.
Well, thanks, Vince. Definitely appreciate hearing about the hiring challenges that you've had, as well as successes. And we've heard stories from across the state on what that looks like for each call center, because really the experiences across Ohio are different across the state. We have different demographics, different work cultures, and we've seen different practices being used on each call center working within their local community to try to overcome that challenge of workforce. We've seen some call centers using remote technology where overnight and weekend staff are not required to come into a call center office to answer the phone. That's becoming a common practice, not just in mental health services, but it's becoming a common practice in most workforces. So the unique ways that we've found to overcome those challenges have been one that we've shared within the community of practice of call centers, for each call center to consider if that will work in their area and if they can adopt that. We've seen other call centers use the funds that Stacy talked about for other incentives. So Vince talked about increasing the hourly wage. We saw other incentive programs that were provided. But what we've heard from all call centers is we have to be responsive and we have to be creative to maintain a workforce. And that is just the key message across Ohio as we've managed to build capacity in the 988 call centers. So with that being said, I want to turn back to Stacy. And Stacy, can you talk a little bit about staffing? Because one of the things that we hear from the public is who is answering the phone, and are they trained? Are they professional? And how do they become ready to answer the phone? So Stacy?
Sure. First of all, anyone who is answering the phone in Ohio, receiving 988 calls, has been approved through an extensive process, a multi-stage process through Vibrant Emotional Health, which is that agency that handles the National Suicide Prevention Lifeline Network on behalf of SAMHSA, the Substance Abuse and Mental Health Services Administration. That includes the call specialists, those folks that take the calls, going through at least 40 hours of training, each one receiving 40 hours. Some of those individuals, well, they have various backgrounds. They aren't all necessarily clinicians, although some of our providers do have all clinicians taking the calls. But what's a common thread across all the providers is that there is a clinician in a supervisory role. So if a call specialist who is not licensed for social work, for example, or clinical counseling, if they get into an issue of concern with one of the callers or texters, then they would call in a supervisor, and someone is with them on call with that clinical background every moment of every day. So that is always that additional level of expertise and knowledge supporting every crisis call that's made. In addition to all that, when we initiated the Ohio Care Line, and that was Prevention Deputy Director Bobby Boyer here at OhioMHAS, she set up a number of Care Line trainings with the Ohio State University College of Social Work. We worked with them to determine what those key trainings needed to be for individuals who took the Care Line calls. And with the 988 work, we transitioned that into a broader look at what do call specialists and call centers need from that crisis call perspective. as Assistant Director Clark said, we know that 80% of the calls that come in are handled through that phone call, and maybe with an additional referral to resources or an outpatient care appointment. So that is similar to what some folks might call the Ohio Care Line about, but crisis calls are another level beyond that. And there's a myriad number of kinds of callers and crises that they would identify for themselves, because it's up to that individual or that family member what that crisis is, what that looks like in that particular instance. So to help address that, we are continuing to work with the OSU College of Social Work to build out dozens and dozens of on-demand and live webinar courses that are available to all call centers across the state of Ohio, not just 988s, but the 105 or 110 total helplines and hotlines across our state, so that everyone can, a rising tide raises all ships. Everyone can benefit from the improvements, the quality enhancements that we're making through the 988 process. At this point in time, there have been over 10,000 courses completed. You see that number in front of you through the OSU College of Social Work courses, and that encompasses nearly 8,000 professional licenses in Ohio. So you see also that not everybody that's taking the courses have a license. Those would be individuals where they're not required to have a license, again, in the call center, but the more they know, the better they can serve the individuals who reach out for help. So we're very excited to have that continue and grow. And as the call centers identify where they might need additional help, let's say working with an individual who is having suicidal thoughts, who might also be part of the LGBTQ population, we have sessions for that. We have sessions specific to individuals with problems with gambling, and they also, may have suicidal thoughts based on those problems. So regardless of kind of the niche where those crisis calls generate from, we are addressing that in trainings and follow-up offerings as needed for the crisis call centers across the state. Thank you, Doug.
Thanks, Stacy. So Stacy was describing all the effort going into preparing a call specialist to answer a call. Vince, I know you are constantly having an eye on the quality of the service that your call specialists are providing to callers coming in. So let's turn our focus just a few moments to quality assurance. Can you talk just a little bit about what that looks like in a call center for you to make sure that that call experience is going the way it should go?
We did receive funding for a quality assurance person from the department, and we just started our person last week. And the good thing is she was already a staff person who had a background in quality assurance and research. So that was very helpful. I still say, though, it's a work in progress because we're still developing that position. But the way we envision it is this person is going to be very involved in the whole 988 process from start to finish, whether this person's involved in trainings and ensuring that our staff are getting the appropriate training for the 988 and how to do suicide related calls. They're going to get more involved in the, we all have in our call centers, many of us have these sophisticated software systems where you can extract a lot of different information. And so we want this person to get more involved in that and start getting doing a deeper dive into, what type of calls we're getting, how they are routed, all those types of things. I think the other thing is just this person should have a good understanding of the suicide crisis hotline and that type of work. So we definitely want them to spend a little bit of time on the crisis hotline. In addition to that, the quality assurance too, with our phone systems and our technology, we are able to do quality assurance in that we can go back and look at, we can listen in on calls that were maybe received the night before and listen to how our staff intervene? What did they say? And provide some constructive feedback. Maybe they said something they shouldn't have said, or didn't give direction like maybe they should have. So we have that ability too. And I envision this person spending a lot more time on that, as well as, we do follow-up calls, with permission. And this person can also be involved in those follow-up calls. And obviously there's more reporting requirements for the department and through the grants we receive. So this person will be providing that information. But again, it's going to be a work in progress since it is new.
Thanks, Vince. It's part of the overall focus that all of us have on the quality of that call. We want the person who is calling to know that it's okay to call. We want the person that's calling to be directed to the right place and to have a good experience, because the work that we're doing is life-changing work, life-saving work. And the weight of that is felt by all of us who are involved. But the opportunity that's there is also a tremendous opportunity. So I'm going to just go around the panel quickly and see if there's some final comments that we have from our panelists before we go to a question and answer session. Stacy, I'll start with you.
I'll go back a little bit to it takes a village, and that nothing has been more true than that in this process. Ohio is, as we all know, a home rule state. So we know that every county, every ADAM board, 19 call centers, it is a number of governmental and community level structures. And then, of course, we have OhioMHAS and SAMHSA, and the call centers, more than anybody else, have to also respond to vibrant emotional health. So multi-level, multi-tiered, and complicated as we continue to focus on quality, on response, so that we can have that individual thrive in the community as the ultimate goal. And we know that folks will call again. And when we talk to our friends within the 911 systems, one of the first things we've heard in our conversations has been the frequent callers they'll reference. And if 988 will help us with those folks that call every day or several times a week, that would be great. Well, in most cases, those are 988 calls. Those are individuals that have behavioral health concerns that we should be able to support them in. And that is what we're in place to do. So I'll just close by saying all of us need to help make this work. And we're happy to hear where it's not working. Well, not happy, but we want to know where it's not working. We want to get that information. We want to dig into that information and determine what that gap was. If there's a challenge, we want to take care of it. And we will handle that, at the state level and at the community level. And if we know who the individual who didn't get the help that they needed is, we'll be happy to help with in that regard as well. But to someone's question, that is more, that information is owned, by the call center. So that would be a matter of permissions. But to the extent possible, we are with all of you in ensuring that the system is effective and is serving Ohioans in need.
Thanks, Stacy. Dwayne, as we turn to you, what can you offer in closing from a county board perspective?
No, I think we need to see how far we've come, and we've come a wonderful way. And there's so much, and again, there's issues we've got to continue, but I think the fact that the department has established a 988 coordinator, I think, or administrator, it speaks volumes that this is important and it's here to stay. And there's some work to do, but I think we'll get there, and the board's working hand in hand with the providers and the centers. And like I said, we've come a long way, and it's exciting, and we're going to save lives. And that's what it's all about, saving lives.
Thanks, Dwayne. Vince, last thoughts from you?
I echo everything everybody else said. I think, the bottom line is what Dwayne said. We are literally saving people's lives. The people who are calling are having thoughts of dying. And it's due to whatever circumstance they're in. And I think we have this ability to, this is National Suicide Prevention Awareness Month. Suicide is preventable, and I like something that Stacy said, it takes a village, but it's not just us as Help Network or the people on the crisis hotline. It's the whole system. It's the whole state. We have to be working together. And I think with the implementation team, that spoke volumes, because you had people on those teams that had come from a lot of different perspectives, and they wear different sets of lenses. And I think, those individuals coming together, we can see the different perspectives. So yes, we just got to continue to do what we do and continue to learn and grow. And again, thank you for this opportunity.
Thanks, Vince. Definitely appreciate those thoughts as well. With that, I'm going to ask Fonda or Molly to join back with us as we can review over any messages that have come in, or any messages and or questions that we can help to answer.
Great. Thank you, panel, for
So,
all that.
Latija, thanks for joining us. You can help as well.
Yeah, we did have we had a couple questions in the chat, and this is kind of there's a couple questions that are interrelated. Instead of asking all of them separately, I'm just going to combine them into one question. People are curious about the process of taking a call, what kind of calls are common, and how do you connect people to resources, whether it's immediate harm to self or others, or if there's another concern, how is that connection made?
From different perspectives, there's probably multiple panel members that would love to jump in and answer that. Vince, I'm going to toss it to you first, just because your center is answering the phone when it rings.
Right. Again, I want to emphasize we are a blended agency, so we are a 211 and a suicide crisis hotline. I've been speaking a lot to the fact lately we have had spikes in calls on our 211 line. If you would have asked me, excuse me, during the pandemic, what were our calls that, most calls we received, it was more for those concrete supports, looking for food, looking for assistance with utilities. Maybe they were going to be evicted. If you look at today, the types of calls we're getting are what we call mental health reassurance calls. Those are top right now, the most calls we're receiving. And I think this is the after effect of the pandemic. There's studies out there that say, 8 months after a natural disaster is really when you start seeing the emotional effect of that. And I think we're there. And so now we're getting these calls from individuals who are saying, I'm depressed, I'm anxious, I've been isolating for months, no social contact, and I'm using substances, to cope. So our staff are receiving those calls, and in turn, sitting and talking to these people, because the other thing we've noticed is we have a minute and 17-second increase in length of calls, and we've been tracking that. Well, it may not sound like much, but when you're getting 1,500 calls a week, that's significant. We're spending more time on the phone with people who are struggling, who are in crisis, and their situations are more complicated. And so we get those calls. If the response is, yes, we receive them, we listen, and then we think about what can help them. What are the resources in the community that could help them? And yes, we refer them out.
Thank you. Did any of the other panelists have a response to that kind of large question?
The only thing I want to say is I think the nice thing about 988 centers is they understand local resources, so they refer people to the resources that are appropriate for them, culturally appropriately, location-wise. And I think that helps, because when you're referring somebody, it always is better if you refer to something that you understand, that you know the service, and you have that comfort level. I think the question was, is there a warm handoff? We're not there yet, but we can say, here's a service provider, they provide this service. If you call and you can ask for this specific service, give them as much information. That's what 988 centers do. So it's sort of a warm handoff to them. But again, I think information referral is local, and we're trying as much as we can to make it local. and provide the support that people need.
Thank you.
I would add that some of the outreach and referrals do happen from a warm handoff perspective, but it's not always like that. It just depends on what that individual wants. He or she or they may not want to, they don't want that connection. They're still making up their minds if they want to take that next step to an appointment, for example, for an outpatient therapy session. Telehealth, it looks again different all over the place. And I think within that, Elijah, was the question regarding if someone is actively suicidal, if there's an immediate need for a crisis response. And the way I read that was it might be a first responder response. If there's a weapon, if someone's life is actively threatened, whether that be the person making the call or the individuals in the area, especially when there's a weapon visible, that is when a 988 center will call 911 in. 988 is about that behavioral health response and mobile response, as Dwayne and Vince mentioned. And mobile response would be set up, if it's available in that community, it would be sent out absolutely at that point to help that individual from that behavioral health perspective. But again, the clinician and the peer supporter are not the ones trained for that life-saving response when there's a weapon in view. When someone says, I just swallowed pills, that kind of thing. That's when you want an emergency squad co-responding with clinical support.
Yeah, thank you for that. So what I'm hearing is when a call comes in, depending on need, resources will be provided that can help meet that need. But if it's more urgent and emergency, kind of that crisis level where someone's in active risk, law enforcement or emergency response may be dispatched to the location. And we have a number of questions and only about 1 more minute to get to these. So I'm going to ask the panelists to get to some of these questions. But we did have a question early on, and it's about geolocation services and if and how those are being used.
That's always a question that we receive because people are used to the services provided by 911. And that's become commonplace practice for 911 to be able to locate a caller through geolocation. Right now, 988 does not have that. That's not just an Ohio thing. That's actually a piece of the federal work that's going on, the national work with the FCC and SAMHSA. We know that it's a need that's there. All call centers, I think, across the country continue to advocate. All stakeholders are advocating for us to accomplish that. But right now, the calls are actually routed by the caller's area code of the phone that they are dialing from. So I had mentioned earlier in the beginning of this panel that we recognize that as one of the challenges that we have, but also that if you were to call a call center, you've got an Ohio area code and you're in California, but you receive an answer from an Ohio call center, even though you're physically located in California. Well, the good news is that Ohio call center is 24/7. They're going to answer the phone. They're going to assess the situation in the same ways. And then they have the means to help that individual locate some local resources as well. Of course, it works best when it's directed to a local place where the person is at. We will get there. Looking back to the 911 analogy, it takes a little bit of time, but we're definitely got our sights on it and we're getting there.
Great, thank you. And we are out of time for the slide question and answer portion, but I already see Stacy going through and typing some responses to the questions in there. So feel free to put those questions in, and we'll turn it over to Fonda, who's going to introduce our next panel. Thank you.
Thank you.
Thank you, Doug, Dwayne, Vince, and Stacy. So now we're going to transition the presentation to an MRSS as well as an OhioRISE presentation. With us today, we have Kelly Smith and Don Pooster, both from the Department of Medicaid. We have Phil Atkins, who serves as the VP Chief Care Coordinator Officer for Harbor Headquarters in Toledo, Ohio. As well, we have Danielle Couton, and she is a crisis/mobile response stabilization services program manager at the Children's Resource Center in Bowling Green, Ohio.
Thanks, Fonda. This is Kelly. Should I go ahead and share my screen?
Yes, Kelly, go ahead and share your screen.
Thanks. Can you see it?
We can see it. Thank you.
Yes.
Awesome, wonderful. All right, well, I'm Kelly Smith and I'm with the Department of Medicaid and I work on our OhioRISE team. And I asked Dawn Pooster to come along with me. She's our OhioRISE Deputy Director. Dawn, do you want to introduce yourself?
Hi, everyone. I'm Dawn Pooster and I have been with Medicaid for about a year now and with OhioRISE for about a year. And I'm really happy to be here to talk about how OhioRISE and MRSS interface together. I have a background of working with mobile crisis. It's something I love and I think is so important in community. So I'm really happy to be here to speak a little bit about it, but also listen to others. So thanks.
Thanks, Dawn. All right, so I'm going to jump right into it. So OhioRISE, as many of you have probably heard all about by now, it has a number of objectives, but the program just launched on July 1st. So it's a new program, and it's really to help serve our youth with complex behavioral health needs and who are involved with multiple systems. One of the things that we want to do is really try to prevent custody relinquishment and better serve our multi-system youth. We've all heard the stories about families that are trying to access costly behavioral health care services, such as residential treatment. So how do we want to do this? We really want to add more intensive in-home and community-based services and supports. When I talk about supports, I'm really thinking about one of the key components of the program, which is care coordination. And we're using the high fidelity wraparound approaches. This really puts families and youth at the center, and it really does try to prioritize their voice and their choice. And that way they stay better engaged and they have better health outcomes. One of the other objectives is really trying to work with our stakeholders. So we've been building this program along with our stakeholders. We've been very transparent and we want to be accountable to them. Another objective has been really trying to work with our sister state agencies as well as the governor's office on OhioRISE. So making sure that OhioRISE is not just built by the Medicaid system or the Department of Mental Health and Addictions agency, but also trying to collaborate across sister agencies to align the program with the different initiatives that they're trying to lift up as well. So I mentioned that the program went live on July 1st. And so now care management entities, as well as Aetna, the OhioRISE plan, are providing care coordination services. There's also the new and improved behavioral health services that are included in the OhioRISE program. And I want to talk just a little bit about who's eligible for OhioRISE. So these are children that are a part of Medicaid or are eligible for Medicaid. They have to be under 21 years old. And they have to, the big piece is they have to require significant behavioral health treatment needs. And this is something that's measured using our new Ohio Child and Adolescent Needs and Strengths, or the CANS assessment tool. Or they could have had a recent inpatient stay in a hospital for behavioral health as their primary diagnosis, or if they stay in a psychiatric residential treatment facility. I really like this slide because it's really just depicting what we want to shift to. So our current state on the left, we really rely on all of our wonderful behavioral health providers across the state to provide outpatient services and our lower intensity services and our out-of-home services. But what we want to do is try to build more intensive in-community services. So our mobile response stabilization crisis service, our in-home therapies like IHBT, our care coordination that's intensive or moderate, and then rely fewer on out-of-home placement services. So how does OhioRISE support youth involved with multiple systems? OhioRISE has the new and enhanced services that are offered through OhioRISE and are now Medicaid billables, such as care coordination, IHBT, MRSS, respite, and flexible dollars. Care coordination will be consistent across the state so that children and youth get access to the same care no matter where they live. And OhioRISE services and supports are community-based to help keep families together. And OhioRISE care coordination will build the system of care over time for multi-system youth. And I just want to mention here that it really is the role of the care management entities to really work with their community partners and build that system of care that we've all been trying to work on for so many years. They actually do have to report back to Aetna Better Health of Ohio, the OhioRISE plan, as well as the Department of Medicaid, so that we can all work together on identifying any gaps that exist in the system of care and then helping to address that so that we can really help our youth and our families. And I'm gonna turn it over to Dawn. She's gonna talk a little bit about mobile response.
Hi, everybody. All right, so I'm going to talk a little bit about the core components of MRSS, and I know Phil and Danielle are probably really well versed in this part of the presentation or these different steps, so please feel free to jump in on here at any point if you want to. So first of all, I'm going to talk a little bit about crisis availability. So this is a program that is available 24/7, 365 days a year. And so each of our mobile crisis teams have a year to meet this operational goal. So after a year, this is the goal, to be a 24/7, 365 day a year program. And some of the reasons I would say is that, you don't plan or predict crisis, so you don't know when it's coming, and so you need to be, so we need teams to be available for that. And the things we can predict are time of day, times of year, things like that. But we also know that availability is incredibly important. And then that uniform triage process, so that when someone calls in a crisis situation, that they get a uniform response across the state. And I think it's also important to note that families define the crisis. So everybody has their own definition of a crisis. What my crisis is not going to be your crisis. So we want to, it's important to remember as you're talking to a family member or to a person on the phone that they get to define what that crisis is for them. So at that point, MRSS will respond to the time and place that the family chooses. So we want to be able to be in their natural environment as much as possible. We do have an opportunity for use of telehealth if that is also their choice. That initial mobile response, like I said, has 24/7 availability. And the requirement is for the MRSS team to get to that crisis situation, to get to that individual within 60 minutes of that triage handoff to MRSS, to the response team. And then that MRSS staff will respond where that child and family is experiencing the problem. So this initial mobile response period or stage lasts for 72 hours. And during that time, there's going to be a crisis assessment, crisis stabilization work that's going to include safety planning and de-escalation in the moment of that crisis. And also within that 72-hour period of time, that mobile response person may also do a CANS assessment, which could determine eligibility for OhioRISE. And then the next stage of the mobile or the MRSS program is this 4 to 6 week of stabilization services. And not every family may need that, but what it does include is a parent and young adult peer support. There are individualized services and supports that are put in place to meet that families and youth's individual needs until more long-term services can be put in place. And so then that leads to number 6, which is that transition. So they'll be developing an individualized transition plan that will include input from the family, and that will be then handed off through a warm handoff to ongoing services that will be supported and put in place. So that's a very basic understanding of kind of those steps that go through the mobile crisis and stabilization services process. And so I would love for our MRSS colleagues and developers, if you have anything to add to that, please go ahead. And if not, I can move on to the next slide. Okay. So how does OhioRISE and MRSS fit together? So MRSS is now a covered service through Medicaid. So it's available to all children and youth through the age of 20 who have Medicaid. And it's also a way for children to be determined. It's one of the pathways for kids to get into OhioRISE. So if an MRSS responder conducts that CANS assessment, that brief CANS assessment to determine eligibility for OhioRISE, then that will be the pathway for them to get into those services. And then the next step for that would be to develop a level or understanding what level of care coordination that youth will receive, and then coordinating with the MRSS provider and other providers around the best services to put in place as they move into gaining those OhioRISE services. So MRSS training for providers. The Center of Excellence provides all the training around fidelity and training for mobile crisis and response, and also conducts fidelity reviews to strengthen those services over time. MRSS is expanding across the state. One, because it's a billable Medicaid service now, so that funding stream allows for more providers to come on board to provide the service. And so right now we have 23 active providers, and they serve about half the state, so about half the counties in the state. So we are always working to build the capacity, because the goal is for us to have that capacity for mobile response for every child all across the state of Ohio. And here are some MRSS resources. So these are the links to the OhioMHAS and ODM, Ohio Administrative Code rules for MRSS, and then also links to the practice standards and 3 different intake, discharge, and benchmark tools for MRSS. And just to give you a little bit of background on where we are with OhioRISE, we launched on July 1st, and we 3 things that we're tracking pretty closely is our number of CANS assessors, because we know that's the pathway to get into OhioRISE for eligibility. And so right now we have 1649 assessors that are registered in the CANS IT system. And we have had 7,280 CANS assessments submitted into the CANS IT system. And that these numbers change every single day. And so far, and this is as of last week, we have enrolled over 10,000 children and youth into OhioRISE, and we anticipate 50 to 60 by the end of the year, or July, by the end of June next year. So it's important, you know, OhioRISE is a very new program. It can feel complicated to families, and so it's important for all of us who understand it and live and breathe it every day to be able to share how to help families get connected with OhioRISE. And so one is to talk to families that you're connected to and other community partners about OhioRISE. We've got, this slide has links to our brochures and flyers that can be really helpful in terms of being a high-level overview of the program and the different services, eligibility, enrollment, and how to schedule a CANS. And then number 2 is information specifically about the CANS assessment. So the flyer for assessors, and then also a flyer for members so that they understand the process and what's happening. And then a big part of OhioRISE with our care management entities is that child and family team who is really directing what services look like with family voice and choice at the center of that. And so here is some information about those child and family teams, and also a link to the care management entity manual that just outlines all of the responsibilities that the CMEs have across the state. And so number 4 is leveraging that CFT process in the child and family centered care plan. So this link gives you more information around the child and family centered care plan, and also link to the training deck and again, the link to the CME manual. But we know that that child and family process and child and family care plan is what is going to leverage the services that youth needs in their community. And then 5 is to provide treatment services to OhioRISE enrolled children and youth. We want to have as many providers within network with A Better Health of Ohio so that kids can have access to the services that they really need. And then reach out to the CMEs to help them build capacity of community resources and natural supports. I know Kelly mentioned that one of the roles of the CMEs is to really help build capacity across the state. And so that is the responsibility of the CME, but not just the responsibility of the CME. That's the responsible of ODM, and A Better Health of Ohio, all of our sister state agencies, because we're all in this together to serve children and youth. And so the CMEs may be the ones who initially identify potential gaps in services. And then together we pave a pathway to increase that in areas where services don't exist for kids. And next slide, please. So just a little bit of additional information around OhioRISE and some of the things that we're doing. We have several office hours where we're right at 90 days in for providing services. Anytime there's a program that's new, there's usually a lot of questions and sometimes a few bumps in the road. So these are some specific office hours that we're having for different groups. So we across the state work really closely with the Family and Children First Councils. And so we do meet with that group every other week just to troubleshoot any things that are coming up, talk about how we can work well together, where we are seeing real success, and then where we have more work to do. And then every Tuesday we have open office hours for any providers to reach out and ask questions about OhioRISE. And then we have specific PCSA office hours for our child welfare partners because they may have specific questions around kids in custody or kids at risk of coming into custody. And then we're going to be starting, we're excited to be able to start doing some office hours for our sister state agency with the Department of Developmental Disabilities to support our ID kids, because we know that there are some unique and specific questions that they might have as well, and different ways that we might support this group.
All right, that's our last slide, Dawn.
Oh, okay. Well, I think I just want to say one more thing, and I'll be really quick. I think that mobile crisis or MRSS is such an important part of OhioRISE. It is a crucial program that needs to be in every community. I'm biased. I did this work for 15 years. I think crisis counselors, crisis responders who do this work every day are amazing. And I think that it's tough work, but it is really, really necessary work. So I don't know if there are any crisis responders on the call today, but I appreciate every single one of you for the work that you're doing. So thank you. And I think there might have been a few questions in the chat, and I think maybe somebody's facilitating those. So I don't want to take over. So I'll.
You know, we can transition over to Phil. If you want to start your presentation, we will entertain all the questions at the end of the session.
Good morning. I see so many friends on the participant list. It's great to have everyone here. This is proof that I am still among living in the state of Ohio and doing work. So it's good to at least virtually see many of your names. I'm going to talk a little bit today about kind of this dual hat that I have worn, both developing MRSS services in the local community, as well as now being with Harbor Care Management Entity, CME, under OhioRISE, how we are envisioning using MRSS. MRSS, I think if I were to have a magic wand, and pick from the umbrella of services that Kelly Smith described that fall under the OhioRISE umbrella, I think that would be the one that I would magically implement first, because I think when we have access to good crisis services, so many of the other things that get called into play, other services and other professionals, we can preempt a lot of that. The unique thing about mobile response and stabilization service in my mind is, our system as behavioral health providers, boards, providers, and our entire system has traditionally been pretty good at crisis. That's one of our core services. We tend to invest a lot in crisis. We saw from Chris Villama's presentation and some of that crisis capacity assessment that there's a lot of federal, state, and local investment that is braided together to make that crisis net. So the interesting thing to me about the MRSS model, however, is the stabilization service. So we know that the crisis definition of what constitutes a crisis in the MRSS space is very different than our typical behavioral health threshold. We have operated on the danger to self or others, definition of what is a crisis for so long. And I can remember when we were starting in Union County, when I was a board director there, to talk about mobile response and stabilization service. We worked with Elizabeth Manley out of the University of Maryland School of Social Work, and I was having just a little bit of fiscal bureaucrat trouble with the idea of sending a licensed clinician out for a crisis as the family defined it, because she was using examples of things like kids won't get up for school, or I think she even said, kid had difficulty getting their locker open. So my mind is thinking about our bandwidth, our resources, And so I pushed back a little bit, and she explained that when she was the state commissioner for New Jersey, she once paid close to $1 million for an Oreo cookie. And I said, okay, I'll bite. What is, what's the story? So she talked about a family that had had several kids in intensive behavioral health treatment. 2 of the siblings were fighting over Oreos. And the escalation just blew out to the point where it was multiple hospital stays, multiple, residential stays. And I don't know if that story is entirely true or just a great illustration, but it struck me that if we can head off at the pass, so much of what happens in a household, we have saved the system and we've saved our family. So my mind changed a little bit about that definition of deploying a mobile response to a house. I think probably the thing that differentiates for me the MRSS model from so much of what we have done is that stabilization service. So I think back to when we started talking a lot about SBIRT, screening, brief intervention, referral to treatment. And we did a lot of training in our systems and our capacities and how to respond with SBIRT. And we were amazing at the screening. We were great at the screening. We knew all of those, validated instruments to use. We had great clinicians on the front line doing the screening. We were also really good at the referral to treatment because that was a usual suspect for us. Okay, we screen somebody and we get them into treatment. But that brief intervention was where we struggled. And I see that being kind of analogous to the stabilization service for MRSS. So the stabilization service, I think, is probably one of the best investments I made in funding MRSS in a community because so many times kids and families just need just that much. And we have between 4 and 42 days to really assist that family to stabilize. And that's, I think, probably the most exciting piece of that stabilization service is the presence of someone with lived experience, that parent peer supporter. And hands down, we got great reviews on our clinicians that were doing MRSS, and we were certainly very fortunate to have a provider that was willing to kind of risk it and try MRSS. But hands down, the feedback that we got was on that parent peer support, that person with lived experience. And I appreciated Nancy Lyons so much this morning sharing her own lived experience, that because it was essential in families kind of feeling that, feeling heard and feeling all of those things that we want for families to experience. We meet people on their worst day. I constantly tell the people that I work with and our team here at Harbor CME that very often we meet people on their worst day. And so we have to remember that when somebody has been there, done that, we up our credibility and their level of safety by making those connections. So I'm very excited about what's happening in the peer support space in Ohio. We are creating an entire new workforce. We're creating a new thing in Ohio when we talk about those parent peers and their role in supporting our systems. I'm also very interested in, as we build out our technologies around MRSS, what are those unique stabilization interventions that we can build capacity around? So, the idea of stabilizing a family in their home for between 4 and 42 days is a very different set of interventions and skills that we need to train our people on than an ongoing counseling relationship or just admitting someone to the hospital if you're a crisis worker, or doing general outpatient or intensive outpatient or inpatient behavioral health services. So the SS part of MRSS, I think is a real growth edge for us as we look at building out some of those interventions that are quick and easy, that are evidence-based, that are portable and even modular as we can plug them in for families and use that time so wisely. One of the things we know about kids and kids in crisis and kids in behavioral health in general is that the dynamics can change really quickly. Kids can have a very intensive, incident or episode of behavioral or emotional need, and then stabilize fairly quickly. That's part of the nature of being a kid and some of their developmental, realities. So we want to make sure that we have great interventions to make that happen as quickly as possible. And before we develop a lot of ongoing patterns that we see maybe in the adult system where that people aren't quite as easy to stabilize. So that's my belief system about MRSS. If I had a magic wand, I think I would make it the first service that came under the OhioRISE umbrella. In the terms of a care management entity, we have all of those pieces and parts that are related to OhioRISE, the IHBT and the MRSS and respite and flexible funding dollars, as well as the care management. The care management entities are really responsible for the moderate care coordination and the intensive care coordination. Moderate care coordination being service coordination with a family-centered team, informed by wraparound principles, but a little bit different in terms of its trajectory and its course. And then, of course, the ICC, the intensive care coordination, being those things that are really based on those high fidelity wraparound models. But we also have a really vested interest in making sure that all of those other pieces and parts are available in communities. MRSS is a backbone of so many of our services. IHBT, it's the backbone of a lot of our crisis services, and it's certainly a key support for our care coordination services. So as just kind of a bit of advice, I'm working, trying in our communities to really identify who is the lead in the development of MRSS for this particular county or this region of counties. I think one of the things that I'm getting used to as a CME that was very different from my experience as a board director is, working in a different configuration of counties. We were organized around state hospital regions, and we were always kind of, those were the kinds of the collaborators that we typically worked with when we worked on joint projects. So now we kind of have a little different configuration. So if the CME in your area can be kind of a conduit to bring information back and forth in a new configuration of counties to run some of these projects that, on a collaborative basis, if that makes sense, then that's certainly what we want to do. So I will yield the balance of my time to my colleague Danielle who is actually on the front lines of MRSS, and let her take it from there.
Thank you, and thank you for having me. So I am Danielle Cutan. I work at the Children's Resource Center in Bowling Green, Ohio, and I have had the pleasure over probably the last year and a half of really developing our MRSS team. So I'm just going to share a couple of things about what it's like having a CME, how we kind of work together, and then also what implementation has looked like over the last year and kind of how things have changed. So Harbor is our CME provider, so our care management entity. And so working with Harbor, we have collaborative meetings to discuss increasing linkages to services and resources for families, identifying levels of care, and really just communicating how we can increase access for families in the community. Harbor is also able to refer to us to complete the CANS assessments. So we are working on training the majority of our staff on being CANS assessors, and our MRSS team all are trained in the CANS assessment as well. Other things, just talking with them about what the future opportunities look like for reaching additional counties outside of Wood County for MRSS services. I think in previous slides it said only 23 providers are able to provide the MRSS service, and I know it is such a big need. We really have seen the benefit of MRSS services, I would say, in our county, with preventing hospitalizations, being able to increase linkage, or with the workforce shortage, even being able to provide families with that support until they're able to get into seeing an ongoing provider. So some other things, just to talk about what our service looks like and how we've implemented it over the last year and really how the program has grown. So within the last year, we've served over 300 youth in Wood County through MRSS services. So out in the community, either doing 72-hour MRSS or offering that 6-week stabilization period. So some questions that we get asked is, what are some common times that crisis is happening, days, things like that. So crisis is family defined. So as we talked in previous slides, families can call, reach out to crisis service for anything that they feel like is a crisis, because we want to step in and be a preventative measure before it escalates to something where they might need 911 or to go to the emergency room. So we never turn anybody away for a crisis situation. Typically, what we have been seeing people for crisis for include suicidal ideations, self-harm ideations. We might see people for family conflict, aggression. Last year, we had some schools who had contacted us regarding kiddos or students making reports, homicidal statements. Very rarely, but sometimes we'll see some psychosis, anxiety, and then school refusal. When school coming up, we get a lot more of that school refusal piece. As far as times of the year when crisis tends to be more busy, so summertime tends to be a little bit more slow. Kiddos aren't in school, things are a little bit more relaxed. Once the school year picks up, though, we tend to get a significant increase in crisis calls. So I would say end of September, so right about now in October tends to be when the busiest time for us. And then around the holidays, it tapers off a little bit. And again, summer just tends to be that slower period. Again, I think it's a little bit more relaxed. There's not as much structure and routine in the summer. And then when the school year starts, they're getting readjusted to being back in school and what that structure looks like. Our weekdays are also more busy than weekends. And a lot of that also goes to inter-referral source. So the schools within our county can call and refer a family for MRSS. So schools are a big referral source that we have as well. Times of day vary. So with MRSS being more prevalent in the school systems, we are getting more calls out during the day as well. So we can go out to the school and provide that crisis intervention at the school. We can go out to the home. And then other times is after school's out, once parents are home from work, we might get more calls around then as well. Overnight, we don't have too many calls, but you get your calls every now and then for overnight after hours. So again, locations tend to be in the schools, in the client's home, and then also hospitals tend to be the main areas where we respond mobily to. So next, moving into staff and workforce development for our program. So we are very lucky. We have our ADAMIS board support for our MRSS and crisis program, which has been monumental in helping us to develop the program. So we had started out at the beginning of last year. We only had, I think it was 2 providers for MRSS, and we were really tracking what the numbers looked like and how many we felt like we would need. So as we tracked numbers, we decided that we needed a lot more providers, especially to be able to provide that stabilization piece, because when you have an influx of incoming crises and you're constantly responding to that, sometimes that stabilization period, you might have to cancel or move that appointment. So we recognize we really need some more providers so that we're able to respond to the initial crisis as well as keep those 6-week stabilization appointments very important. So we participate monthly learning communities with the Center of Excellence and other MRSS entities, just to talk about how things are going, barriers, implementation process, and then also can do some case presentations. So that has been very helpful, I would say, for us. We have a consultant, Sarah Becker from Connecticut. She has also been very monumental in helping develop our program. So I meet with her, once every other week just to talk about how things are going and upcoming things with the state. So currently we do have 5 licensed providers. We have a qualified mental health specialist and also a peer support. So out of those 5 licensed providers, they can provide crisis during the daytime as well as after hours. We are in the process of working towards that 24/7 implementation. So currently we're working on training our weekend providers in MRSS as well. Our goal is by January 1st, we will be having MRSS 24/7. So that's a big step for us. We are all trained in CANS again, so we want to be able to get the CANS completed at the crisis assessment if we're able to, so we can get those families enrolled in OhioRISE. And then just some other things that have been very helpful for, I would say, our community is we have a community crisis team meeting once a week with community partners. So that can include people from the hospital, local police departments, Board of DD is there, the adult crisis service team is there, and we meet once a week just to talk about how things are going, the implementation process. Is there any systemic issues that we can work on? So that's a really great way just to talk through different things going on in the community and how we can ensure that people are getting the appropriate care. We also have monthly meetings with 988 as well as the MRSS call center regarding how communication's going, how that service flow is going, making sure that there's no barriers, just having open communication about how those things are working. So that is what I have. So I think next was to go into question and answer. Is that right, Fonda?
Yes.
Elijah?
Yeah. We have a number of questions, so I'll invite all the panelists for this session to come on. Some of these questions might be a little bit specific, so I'll try to make this kind of relevant for everyone. But there are there's a question about accessing MRSS, and I think with the number of initiatives Ohio has, I think it bears repeating this answer. Do families access MRSS through OhioRISE by calling 988?
So I'll start, and then I would love Danielle or Phil for you to jump in. You don't have to have OhioRISE to make that initial call. So, but what can happen is that if you do call MRSS and you are linked to a responder who comes out to provide an assessment, then they may complete a CANS assessment, which would then determine your eligibility for OhioRISE once it's entered into the CANS IT system. So that is one of 3 pathways to get into OhioRISE through Medicaid. And I don't know if anybody wants to expand on that around the 998 to the mobile response team or not, but
I'd be happy to just add, and I think what I put in the Q&A did mention 988, but yes, there is the separate MRSS call center number, which I do not have memorized, but I'm sure it's been shared. I'll look it up and add it to the response. Thank you.
thank you.
And that might be a good number for us to share after this webinar. So 988, there's a 988, and then there's a specific number families can access MRSS through. Another question we have is, there's 2 questions kind of around funding. One is, if families don't have Medicaid, how is MRSS funded? And the other is, what is flexible funding money for MRSS? So I don't know who'd like to attempt those, take a stab at answering those.
Oh, okay. Well, I can tell you the flexible funding that was talked about under the OhioRISE umbrella is not specifically affiliated with MRSS. So one of the things that the OhioRISE design team noted was that very often families have unique needs that are kind of one-offs, or that they may not be considered, they may not be in the general billable taxonomy, but family could be really helpful for families. So youth who are enrolled in OhioRISE at any level of care coordination, low, moderate, or high, have access to a pot of flexible funds that is determined on their care plan. And so we have submitted things like we have a kid who is enrolled in karate now and helping with the dojo. We knew that that was an anger management issue. We have kids that are getting some additional adaptive equipment for kind of sensory room to de-escalate. So those funds are part of the larger OhioRISE umbrella and not specifically associated with MRSS. How do they do Medicaid?
I would say if a family doesn't have Medicaid, or they have private insurance, then you partner with your local ADAMAS board. That is who provides our funding for that. So that would be who I would reach out to if you have questions about that funding.
Thank you. Another question we have is, of the 10,171 OhioRISE enrollees, how many were new to Medicaid? And really related to that, is this reducing the number of people uninsured in Ohio?
I think that is a great question, and I do not have the statistics to answer that today. I don't know that we can definitely get that breakdown, but we haven't done that breakdown yet. So it's something that I'm glad you asked the question, and it's something that we can follow up on and reach back out and share that information.
One of the challenges with OhioRISE out the gate is that, we have kind of a roster of first day enrollees. They did a look back on certain types of claims that kids had in the months leading up to the launch of OhioRISE July 1, and gave all of the care management entities a day one list. Like, these are kids who would be reasonably, we would think that might be eligible for OhioRISE. Well, given that, we had a global pandemic and redeterminations, were paused, and some of the data in terms of the contact information has been a challenge. We know that a lot of our families don't stay in one place for 2 years very long, or their cell phone numbers change, or things like that. So one of our strategies as Harbor CME has been to really work in facilitating business associate agreements and memoranda of understanding with our local FCFCs, our local ADAM boards, our providers in our community, to say, hey, we're going to protect ourselves a little bit and be able to share some of this contact information for the purpose of facilitating services and getting a good contact roster. So that has been a challenge, but certainly a role for providers and boards. If your CME hasn't reached out to you, if you want to email me, p@atkins@harbor.org, I'm more than willing to share copies of those agreements.
I will say one other thing about the OhioRISE program is that there is what's called a 1915C waiver, which is a special part of OhioRISE that is specific to meeting a certain or meeting an inpatient level of care and having a documented behavioral health diagnosis. And that is for kids that have a really high level of need. So kids that are on the waiver are in OhioRISE can get this waiver, but also kids who are not in OhioRISE could potentially be eligible for that 1915C waiver, those services, and get enrolled into Medicaid and OhioRISE through that. And so we have 1,000 slots for that in the first year of OhioRISE. So that's just one other opportunity to get involved in OhioRISE for potentially for Medicaid enrolled and non-Medicaid enrolled kids.
Great. Well, I do apologize. We don't have time to get to all of these questions. But I want to just thank the panelists for taking the time this morning, afternoon to be with us today and talk about the, these new services to Ohio. So I appreciate that. And I'll invite Molly to come back to give us some kind of final instructions as we get ready to close out this webinar.
Yes, and like Elijah said, thank you to all of you for participating, and thank you again to our panelists for a great academy. I'd also like to thank our sponsor, the Ohio Department of Mental Health and Addiction Services. The link to the SurveyMonkey evaluation is now in the chat. You will also receive this link in an email sent out later today by me. Please complete this evaluation to receive your continuing education credits, and as well to help us inform our future trainings. Have a great rest of your day.